Good day and welcome to our usual series, the latest in our usual series of ongoing Q&As about the coronavirus, vaccines, and communications, sort of in the world of the variants and such. I'm Lawrence Carter Long, the Director of Communications at the Disability Rights Education and Defense Fund. Joining us today for a necessary conversation on COVID-19 variants and vaccine hesitation. We're going to have a discussion with Dr. Rebecca Fielding Miller, Assistant Professor at UC San Diego at the Herbert Wertheim School of Public Health and the Division of Infectious Disease and Global Public Health, and a faculty member of the Center on Gender Equity and Health. Her research is community-driven and examines structural drivers of COVID-19, HIV, and gender-based violence in the United States and sub-Saharan Africa, with a focus on the intersection of race, gender, and economic inequality. Dr. Fielding Miller holds a PhD in behavioral sciences and health education from Emory University and is an MSPH in international health, with a focus on social and behavioral interventions from the Johns Hopkins Bloomberg School of Public Health. And I suspect folks watching will also, many might know her as Steve Miller's daughter of the Tierra del Sol Foundation in Los Angeles, which is not a place, but rather a dynamic organization that empowers people with developmental disabilities to achieve excellence through workforce development, college to career, and careers in the arts. So thank you for joining us today, Dr. Fielding Miller.
Thank you. It's such a pleasure to be here and to have the opportunity to talk to you about vaccines and variants and potentially how to talk to friends and neighbors in folks' lives who might be concerned about getting the vaccine.
Yes, a particularly timely topic, I think, today with all the questions and the discussions we've seen on misinformation. So I'll hop out for a little while. We'll enjoy your presentation, and then I'll come back on for the Q&A. Thank you again, and thank you, Brandon, for doing the ASL.
And in true professor fashion, I brought my slides, of course. I don't know that we can do anything without slides. So there we go, which I'm pretty sure you're looking at. So I know that vaccines and COVID and masking have been very much in our national conversation yet again. I think some folks, myself included, were hoping we would be done by now, but I guess we're not. So what you're looking at right now is a map of the United States in graphs. And you can see some of these little squares are darker red, some of them are lighter red, a couple of them tinge toward green. And this is the trend in COVID-19 infections by state across the United States. And across the United States, pretty much all of these graphs have a very large peak in January, and that was that winter and fall that we just all experienced, that came down again, especially as vaccines became available. And now many states, many of these little tiles are turning red again. And if you look at the far right on each of these little squares, you'll see that many case numbers in many states are starting to tick up, including here in California, where I live. In particular, the South, so Louisiana is the darkest red square on here with very high rates of COVID-19. In fact, similar to what they saw last winter. Mississippi, Alabama, Georgia, Arkansas, Tennessee, South Carolina, also all have very, very high rates of COVID-19. And one of the big things that is driving this is this new variant that folks have probably heard about in the news so much lately, this Delta variant. And this variant is the one that was also associated with really large and frightening outbreaks in India, and became dominant very quickly and spread throughout the UK, throughout Israel, and now through the United States. And one thing that's important to know about this variant is it appears as if it is so much better at getting people sick, because when people do get ill, they what's called, they shed a lot more virus. So if you are infected with COVID-19 and you cough or breathe or sneeze or sing, you are potentially putting out 1,000 times more pieces of virus if you're infected with this variation than with the initial virus. So that's really scary because it means that more people can become infected because there's just more virus in the air. And it also means that if you have more virus in your system, you're going to be sicker. So that's really scary. And a lot of these trends that you see upward really are primarily among people who are not vaccinated. And you might hear from time to time this idea of this is a pandemic of the unvaccinated. And I don't actually really love that phrasing. And I'll talk about why in a second. So these are numbers from here in California. And I'm going to talk mostly about California and a little bit about San Diego because this is where I know really well. But I think the principles will stand pretty well. So here in California, the people who have really had the most cases are people 18 to 50. These are some graphs where there's a vertical line that shows the percent of people, 18 to 49 who make up the state population compared to what percent of people were actually infected. So about 58% of cases in California were among people ages 18 to 49, but people ages 18 to 49 only make up, let's say, about 50% of the state population. On the right here are confirmed deaths in California by age. And what we can see in this graph in particular is that people who are over 65 accounted for 73% of deaths in California, even though they're only approximately, let's say about 10% of the population in the state. And we know this and we've heard this a lot, right? That the elderly are at extremely higher risk. And that's one of the reasons that when the vaccines first rolled out, they were first prioritized to healthcare workers, of course. And then after that, the highest priority was people who were older. And I think most people could agree on that. And afterwards, the conversation got a little bit muddled about who should be next in line. And I think in particular, folks with disabilities really did try to advocate that disability should be a qualifying condition to move up in the line. And, you know, I wish we'd done that better, or that had been done better. So the other thing to think about in terms of who is getting sick is it's not just by age differences. There's a lot of reasons why certain people are getting sick more than others. So here, these are some more graphs with data from California, where we can see that the vast majority of the case rates, so the number of people per 100,000, were a lot higher in racialized, ethnic, and minority populations. So Black and African American Californians had an enormously high rate of COVID-19 infection in California. About 177 per 100,000 people had been infected by early July. Also, Native Hawaiian and Pacific Islander, Native American and Alaska Natives all had very high rates of COVID-19. And Latino Californians also had really elevated rates of COVID-19. And, you know, in particular, compared to white Californians who had among the lowest rates. So we see this trend of risk by race and ethnicity. And that trend continues for death too. We see the same patterns play out. So Black and African American Californians had one of the highest death rates in California, followed by Latino Californians and then white Californians. And these are the same differences that we see for pretty much every illness. We know that people who are minoritized, people who are marginalized by race, ethnicity, by disability, by class, by gender, almost always bear the brunt of disease and infection. And it doesn't have anything to do with people's biology or anything like that. It has to do with what experiences people tend to have and what access they tend to have. So, for example, in California, one of the occupations that had the highest rate of mortality and morbidity, people who got sick the most, was actually line cooks. So, people in kitchens who make very little money were actually um, had the highest rates of COVID-19 sickness. And that's because it's a job without sick pay that is paid very low. You're working in a very confined space, and there tends to be a lot of shouting. So the occupation itself is risky. What people are doing is risky, and the people working in these risky occupations tend to be people who are otherwise marginalized and only given access to risky occupations. So fortunately, we did develop these vaccines in unbelievably rapid time. It's just really a little bit of a miracle how quickly we had access to these vaccines. And I think it's a real testament to a good luck, but also what happens if you are willing to throw enough money and enough very smart people's time at a problem. And it's just really fabulous that we have these. And so this here is another graph of when people got vaccinated, basically, and how many people are vaccinated. So we can see in this graph, the first line is people who are above 65, and we see here in California that right about February is when people over 65 became eligible, and that number climbs very quickly. After that are people with kind of sort of any, I think, uh, comorbid conditions, sort of anything that would make COVID-19 infection worse, kind of became eligible around April 1st, which is about when the governor, as far as I could tell, just sort of threw the door open. And right around April 15th is when every adult in California became eligible for vaccines in our state. And so you can see sort of this green line climbing very, very quickly in February, followed by a red line in late March, early April, and an orange line that kind of climbs a little more slowly starting around April 15th, and that's different age groups. And then right about June is when vaccines became available for people 12 and older, which is when those numbers began to climb. And overall, people age 65 and up tend to be very well vaccinated. About 70% of people 65 and up in California are fully vaccinated. 70% of people 50 to 64. And then as people get younger, how likely they are to vaccinate tends to drop because, well, that's for a lot of reasons. We can also look at these data by race and ethnicity. So we can see that in California, again, white Californians are very well vaccinated. About 60% of white Californians are fully vaccinated, 42% of Latino Californians. But in terms of percentage, um, very few African American, multiracial, API Native Californians are vaccinated. And that is for a lot of reasons that again have to do with access, but about who has a history of being treated poorly in the medical system, some issues with ethics and how we've done medical research in the past that people don't forget. But one thing that is really important about this is you'll notice I'm showing data disaggregated by all types of different things, by age, by race, you can get it by gender. In California, I believe we track LGBT status in terms of infections. But these data, as far as I can tell, are not easily available by disability status. And I find that a little frustrating and concerning because if we don't know whether or not people are getting vaccinated, we don't know if we need to fix it or not. We don't know how to make it better. So I invite you to kind of have those numbers in mind and look at this map again. And if we start thinking about COVID in many ways as an occupational risk and as a risk of people who we have traditionally treated less well in our society and pushed to the margins and asked to do hard and dangerous things, I think this map begins to make even more sense. This is the same map of case rates across the US. And in fact, when you look at sort of a county-wide map, for example, in Georgia and Alabama, there's this line of counties that is historically called the Black Belt that tend to be heavily African American. And you can actually see in this same line of counties lower rates of vaccination and higher rates of excess mortality as a result of a lack of vaccination. But while those numbers are going up, these data are from San Diego. I just really love graphs. I just think they're so great. And I find this graph really reassuring. So I think as cases go up, I think a lot of people are starting to know somebody who's had what we call a breakthrough infection. So, well, my neighbor was fully vaccinated, but she got COVID. So, do the vaccines even work? Or, my family went to a cookout and 2 of the kids had COVID, and before you know it, 5 of the adults had COVID. So, what good are the vaccines? And it feels scary to hear these stories. But if we look at the actual numbers, I personally find it really comforting. So this is where we are in San Diego as of today. In San Diego, we too are having our numbers just go up very, very high. We have a case rate right now of about overall about 15 cases per 100,000, which is pretty bad. But if you look, there's an orange line that's climbing just vertically. It's like a mountain. It's like Everest, and it's just shooting up. But below that, there's a dotted green line that's actually staying quite flat and has a little bit of a bump, but isn't climbing at all. And that orange line is people who are not vaccinated, and the green line is people who are vaccinated. And if you kind of play with these numbers a little bit, you can see that people who are not vaccinated, people who are vaccinated are still making up only maybe 15% of cases week to week, even with the Delta variant. And that's really good news. We're going to hear about more breakthrough cases because if there are 20 cases and 10% of them are among people who are vaccinated, that's 2 people. But if there's 200 cases and 10% of them are among people who are vaccinated, that's 20 people. And 20 people is a lot and it feels really scary. But what we're still seeing is really strong effectiveness in these vaccines. I just have to say that because I go back to this chart a lot to feel comforted. Similarly, the vaccines also do an amazing job, even with Delta, of turning the experience of becoming infected. It's the difference between, being in the hospital, being very, very ill, and a weekend feeling crummy, which is a big difference. That's a big difference those vaccines can make, even with a breakthrough infection. So I said before that it's really frustrating that we don't have data on whether or not on vaccine access for people who are disabled. And that's because these vaccines are so important. And because we know people who are living with a number of different disabilities are at higher risk. There was a study from the UK that found that about 6 in 10 COVID-19 deaths in the UK were among people with disabilities. And that is, again, not necessarily biological. It has to do with the fact that people who are disabled, they may have less good access to medical care. They may be working in jobs that don't have access to as much paid sick leave or benefits for all the reasons that people with disabilities are marginalized in our society. Just like racial and ethnic minorities are marginalized, those are the same things that put people at risk. And so I could find really one study from Montana about vaccination rates among people with disabilities. And one of the things they pointed out is, not surprisingly, people who are disabled have the exact same vaccine hesitancy concerns as everybody else. And I think that's probably not a surprise to many people listening to this. And so when we look at who is really concerned about accessing vaccines or who isn't vaccinated, it tends to be people who are younger, people who are potentially more politically conservative, people who are white, often people who are rural. And the things people say that they're really worried about are things like, I'm worried about side effects. I'm worried that I don't know how to find a place where I can get vaccinated. There's a lot of rumors that people hear out here. But when people hear somebody they trust, a friend or a doctor or a family member say something like, well, the vaccines are almost 100% effective at preventing hospitalization and death, people find that really persuasive. This is a graph of how persuasive different sets of people who are hesitant to get the vaccine, how persuasive they find different messages. This is from the Kaiser Family Foundation. And it's a little bit busy, but I'll just tell you, and you can trust me, that when you say the vaccines prevent hospitalization and death, people find that really compelling if they are a little hesitant. When you take a minute and talk to people about, well, the COVID-19 vaccines are new, but the technology is stuff we've been doing and working on for 20 years. That's actually really reassuring and compelling. When you tell people how many people participated in these trials, so over 100,000 people from all these different backgrounds, again, we don't have data on how many of them identified as having a disability, and I would guess from the way these trials work that people with disability were probably purposefully excluded, which is really problematic. But in general, how many people participated in these trials, people find really comforting. That doctors are willing to take the vaccine is comforting, that it's free, and that, even if we don't know the long-term effects of the vaccine, we know the long-term effects of COVID can be really bad. These are all things that people find really comforting to hear and can be kind of convincing. And I'll stop there so we can have an actual conversation. But I will say that the person who folks who are not yet vaccinated find the most trustworthy are their friends and their family. And so if you are feeling concerned about these climbing numbers, if you are worried about people in your life, honestly, one of the most loving, if potentially awkward things you can do is just start up a conversation about the vaccines and keep those lines of communication open. So I will stop there. That's plenty of PowerPoint, and I'm really excited to just have a conversation.
Thank you so much for that overview. And I wanted to. You mentioned earlier that you weren't fond, or you didn't think it was the best messaging to say that this is becoming a pandemic of the unvaccinated. And I was wondering if we could maybe jump into that a little bit. And I know that, let's say that, that this is something that has started to become almost a meme, if you will, or a talking point. San Francisco Mayor London Breed tweeted last week that if you're not vaccinated, it's likely not a matter of when you'll get it, or if you'll get it, but when and how bad it will be when you do. So it would seem to me that in these cases, somebody who does the communications for DREDA, the nuances are important here. So what would you tweak in that messaging, and why? And why is that important?
Yeah, so I think there's a couple things worth tweaking or thinking about in that message. So first, we know that unfortunately, fear tactics can be kind of useful in the short term, but not necessarily in the long term. So rather than saying, well, you're just going to get sick if you don't do this, just like in that messaging, in that poll, it's actually a lot more productive, proactive to say, well, if you do get vaccinated, even if you get sick, you're a lot less likely to go to the hospital and die. But the other reason I don't really love this pandemic of the unvaccinated rhetoric is it ignores a few things. First, It ignores the fact that these breakthrough infections are more likely in people who are elderly, who are immunocompromised, who are disabled in some way. And so by putting this individual onus and saying basically, well, it's just unvaccinated people and it's their own fault who are getting sick, that's not honest or helpful. There are also people under the age of 12 in our society, who many of us like, who are not yet eligible to get vaccinated. And I understand that we as a country really value rugged individualism, and I think that's something great about us. But it's also not really helpful in a public health crisis when um, getting vaccinated is really helpful to yourself as an individual, but it's also a social act that protects other people. And the more people who do it, the more people who the vaccines don't work as well, if they're immunocompromised or they can't get them because they're 12, then those people are protected.
So, and I think that's really important, especially, at the time that we're recording this, the most recent data I've seen said that infections are up 300%. And that's coming out of the CDC, the Centers for Disease Control and Prevention, and that people are once again advising that we wear face masks indoors, largely because of the Delta variant, which is reported to be more infectious. If there was something sort of around those issues that you felt was maybe underreported or hasn't been discussed as much, that you'd like people to know surrounding those things, what maybe would that be?
Mhm. I mean, I think masking is a really good idea and really important, and I'm glad that it has kind of entered the conversation again because we know that people who are vaccinated can have breakthrough infections, although they're uncommon. And one thing that seems to be pretty different about the Delta variant is because if you're sick, there's so much virus in your system and in your breath. People who are vaccinated also appear to be a lot more able to spread the infection if they do get sick than we initially thought with these other variants. So even if you are vaccinated, it's really important to wear a mask because if you do get infected, I hope it's a very, very, very mild infection that maybe you can't even tell, but you're still going to be breathing out virus. Similar, even if you are vaccinated and you're not infected yourself, it's possible that maybe the vaccine just didn't take for some reason. And third, and the thing I tell my daughter, this is a collective action. It's public health, and we wear masks to show people we care about them. And so it is a caring public act to wear a mask.
So would it be fair to say then that the emphasis maybe should be shifting from um, sort of the individual liberty or the it's my choice kind of focus, which has we've seen I think in the culture and by extension in the media, to more of a public focus, in that it's not necessarily, we shouldn't be so concerned about what we're breathing in, that maybe it's more, just as important, if not more so, to focus on what we're breathing out, right? So not necessarily how it may affect me for whatever reasons, but how it might harm those around you.
Hmm. Yeah, very much so. And fortunately, the same thing that's going to protect you is going to protect other people. So you really get a two for one.
Right, and so it's a win-win all the way around, regardless of how you message it, right?
Hmm.
But that messaging could be crucial in sort of making that leap right over the hesitations
Hmm.
that people have. I wondered if you had any thoughts in how things are changing, well, yet again here in California. The state is going to make it mandatory for all state employees to show proof of vaccination beginning on August 2nd, or they're going to ask that people get tested weekly, and that healthcare and congregate care employees have until August 23rd for the same, and hospital workers are encouraged to wear N95 masks. Um, um, in terms of what you're seeing in the data out there, Why do you think this guidance is warranted? And is there anything else you'd like to people to consider surrounding it?
Hmm. Yeah, I think it can feel uncomfortable um, to this idea of a vaccine mandate, but I think one, we have to remember that vaccine mandates are not new, actually. Every child who enrolls in public school um, gets a series of vaccines, normal childhood vaccines just to enroll in kindergarten or first grade, or to enroll in a public university. It's not new that we expect people to be vaccinated from communicable diseases to protect people around them. It's really, really common. The other thing is, I think we can actually think of this as an accessibility issue. So
How
everybody,
is, and yeah, how so? Unpack that a little bit.
yeah. So everybody should have the right to be able to go into their city or state government office if they need to take care of some sort of business, if you need to get a piece of paperwork or your birth certificate or file something. And if it is unsafe for somebody to go into a public facility because they don't know if people are unvaccinated and there's an airborne communicable disease, then that space is not accessible. And I actually think there's a really similar argument to be made for these places that we deemed essential, like grocery stores, um, pharmacies. Those are places that everybody needs to have access to, that everybody needs to feel safe to be in our society. And so it is a shame to think of oneself as a potential accessibility issue, but that's just how diseases work like this.
And so, yeah, something that should be I discussed more, put in the forefront of the conversation rather than an afterthought, which is,
Hmm.
as we've been following this over the last year and a half, as you mentioned in your presentation, we found that disability communities have often been last in the conversation, despite our shouting it from the rooftops, and sending those messages and being part of some of these conversations on a state and on a national level. I wanted to bring one final point. You mentioned how data is not easily available on one's disability status. And I wondered if you had any, and this is something we found as well, that you can't make adequate recommendations about what needs to change if you don't have the information which informs that, right? And so in that regard, do you have suggestions or recommendations on what you'd like to see in order to change that so that we can collect that data? What do you think needs to be done so that we don't find ourselves in similar situations in the future?
Yeah, so I think this community in particular has such an amazing, rich history of advocacy and activism. Um, and I think it is unfortunately probably going to be necessary to tap into that again to make sure these data become available. So, for example, in California, one of the standard statistics that gets collected now when you take a COVID test, we want to know who is sick by age, by race, ethnicity, by gender. And there was some strong lobbying to make sure that sexual orientation was included in that. So people may find in California that they're asked about their sexual orientation when they get a COVID test. And that's because the community really advocated for those numbers so that they could have a portrait of what's going on. And I think it's possible that similar advocacy efforts to just get a box on a form to begin collecting and disaggregating those data would go a really long way.
Yeah, and what if you had your ideal world, right?
Yeah.
What would you want that box to simply ask?
If I had my ideal world, I would not be the one defining what that box is. You all would. Um, I think that's a conversation that needs to come out of the community and really thinking about what is the way to ask that and what do we want to know and then my job is to just continue to push for that and agree that that is valid and necessary and then to play with the data later.
Okay, so that's sort of informed or driven by those communities themselves, but in a way that you can then compile and aggregate and make sense of that data.
Hmm.
Um,
Yeah.
um, Excellent. Diplomatically placed, and I think well was it. Is there any other thing that we didn't talk about or that might have occurred to you during the course of the conversation that wasn't addressed that you'd like to leave folks with?
No, I think that I mentioned that really one of the most kind things people can do for folks in their life who are a little worried about the vaccine is to just start the conversation. And um, some people who are already vaccinated might feel frustrated if they know people who aren't already. And I understand that frustration, but I will say that the best possible way to approach these conversations is with compassion and empathy. It turns out nobody has ever changed their mind because somebody yelled at them and called them nasty names. It's not a very persuasive technique. Um, but if you can approach people in genuine kindness and care and empathy, that's going to be a lot more effective. And when you do eventually get through to them, if you do, it's going to feel really great.
And it'll be because it's something they decided to do
Hmm.
rather than they felt like they were pressured or their arms were twisted or whatever other metaphors we might use. Well, I thank you very kindly for taking some time this afternoon to kind of address these questions and to discuss them with us. I realize it's a busy time for you right now, and that probably isn't going to end anytime soon. So we thank you very kindly for your time and your expertise and your insights, and wish you good luck going forward. And thank you, Brandon, as always, for interpreting for us today.
Thank you.